All right, let's jump into a deep dive today. And we're tackling DKA and HHS full-on medical PDFs this time. So by the end of this, you'll have a way better grasp on these conditions, how they're different, how to treat them, and what nurses really got to know.
Yeah, these conditions can get out of control fast if we don't catch them early.
I know, right? And get this, even a patient's breath can be a huge red flag. Plus, there's this handy mnemonic to remember which type of diabetes goes with which condition. DKA comes first in the alphabet, just like type 1.
Yeah, that's a good one.
Ready to dive in?
Absolutely. But let's start with some diabetes mellitus 101. Got to make sure we're all on the same page, right?
Okay, sounds good.
So the main difference between type 1 and type 2 diabetes is all about insulin. In type 1, the body's immune system goes rogue. It attacks the cells that make insulin, so no more insulin production. Big problem. Now, type 2, it's a different story. The body's cells just stop responding to insulin signals. Like insulin's knocking on the door to deliver glucose, but no one's home.
So the delivery truck's there, but the address is wrong.
Exactly, and this usually comes down to lifestyle, especially what we eat.
Makes sense.
And without insulin doing its job, glucose can't get into the cells to provide energy, and that's when things start to go haywire. Plus, insulin also helps regulate potassium, which is super important for your heart and muscles.
Oh, right, electrolytes.
Yeah.
But what about glycogen? Doesn't the liver store some glucose for later?
Yeah, the liver's like a backup energy bank storing glucose as glycogen, but that reserve can only hold so much, and when it's maxed out, especially without insulin to manage things, that's when we see complications like DKA and HHS pop up.
Okay, that makes a lot more sense. So let's dive into DKA. This one sounds like a real medical emergency.
It is, and it can develop really fast. Remember how we said DKA often shows up with type 1 diabetes?
Yeah, DKA comes first, just like type 1.
Right. Well, the acronym itself actually tells us what's happening in the body.
Okay, let's break it down. D is for.
Dry and high sugar. We're talking super high blood glucose levels and severe dehydration. Like, imagine someone losing 10% of their body weight in fluids. That's how bad DKA can get.
Wow, that's terrifying. Okay, what about the K?
K is for ketones and Kussmaul respirations. Without insulin, the body's like, gotta find energy somewhere, so it starts breaking down fat. This process creates ketones, which build up in the blood, and that makes the patient's breath smell fruity, kind of like nail polish remover.
Oh, wow.
And their breathing changes, too, becomes deep and rapid. We call it Kussmaul respirations. It's like the body's gasping for air, trying to counter the acidity from all those ketones.
So high blood sugar, dehydration, ketones, and struggling to breathe, that's a lot going on. What about the A?
A is for abdominal pain and acidosis. All those ketones hanging out in the blood can cause some serious stomach pain, but the real danger is metabolic acidosis. That's when the blood becomes too acidic, throws the body's whole chemistry out of whack. And if it's not treated, it can lead to coma or even death.
That's really scary. So what are some things that can trigger DKA?
Well, there's a helpful mnemonic for that, too. The 4 S's, sepsis. That's when an infection spreads through the bloodstream. Sickness, like a stomach bug or the flu. Stress from things like surgery or even just being in the hospital. And skipping insulin doses. Any of these can push the body over the edge and lead to DKA.
Okay, so it's like a perfect storm of factors. This has been incredibly insightful. Now, let's shift gears and talk about HHS.
All right, sounds good. So HHNS is usually associated with type 2 diabetes, just like HHNS comes after DKA in the alphabet, right?
Right.
And it's a bit sneakier, often affects older folks. And here's a key difference. While DKA patients are at higher risk from low potassium, HHNS patients are more likely to die from being severely dehydrated.
Really? Why is HHNS harder to spot than DKA?
Well, the symptoms usually come on more gradually. Easy to miss, especially in older adults who might already have other health issues going on. Let's unpack the acronym.
Okay, the first H.
Stands for highest sugar. Blood glucose levels go even higher than in DKA, sometimes reach crazy high levels. And this extreme hyperglycemia is what drives the second H. Higher fluid loss and extreme dehydration. The body's trying to flush out all that extra sugar through urine. Leads to a ton of fluid loss.
So the body's basically trying to pee its way out of trouble.
Pretty much.
And the N in HHNS.
That's head change, LOC, confusion, neurological manifestations. Basically, the brain doesn't like it when blood sugar and electrolytes are out of whack. When blood sugar is through the roof and the body's parched, brain function takes a hit. You might see anything from mild confusion to seizures and coma.
So high blood sugar messes with the brain too. What about the S? Is it like DKA with ketones and acidosis?
Nope, that's where HHNS is different. S stands for no ketones, no acidosis. The body's not breaking down fat for energy in HHNS, so no ketone buildup or fruity breath. And potassium levels tend to be more stable.
Interesting. So both DKA and HHNS are serious diabetes complications, but they show up in different ways and need different approaches to treatment.
Absolutely. Speaking of treatment, what jumped out at you from what you read about how to manage these conditions?
Well, there was a lot about how urgent it is to act quickly. Like every minute counts.
You're absolutely right. For DKA, the first thing we do is tackle the dehydration. We start by giving 0.9% normal saline intravenously. Got to get those fluids back ASB.
Right, that makes sense. But what about the super high blood sugar? Don't we need to bring that down fast too?
We do, but it's got to be done carefully, like landing a plane. If we give insulin too quickly, the blood sugar can plummet. And that can cause some serious complications, like cerebral edema, especially in kids.
Oh, wow. So it's a delicate balance. I also remember reading something about potassium being a concern during treatment.
Yeah, potassium levels can be all over the place in DKA. And insulin itself can actually make potassium levels drop even more. So we keep a close eye on potassium and often give it intravenously, even if levels seem okay at first.
So it's all about staying ahead of the curve. It sounds like managing DKA involves a lot of close monitoring and making adjustments as you go. What about HHNS? How is the treatment different?
Well, for HHNS, rehydration is the top priority. Remember, these patients are severely dehydrated. We start with 0.9% normal saline, same as in DKA. But then we often switch to a hypotonic solution.
Can you explain what a hypotonic solution is and why use it for HHNS?
Sure, a hypotonic solution has fewer solutes compared to the fluid inside the body cells. This difference in concentration helps pull water into the cells, rehydrating them better.
So it's like luring the water back into those thirsty cells. What about the high blood sugar in HHNS? How do we manage that?
Insulin's still key for HHNS, but we got to be extra cautious. We usually give it intravenously, and the dosage needs to be tweaked frequently based on the patient's blood sugar levels and how they're responding.
So it's constant back and forth. This really shows how crucial nurses are in managing these complex situations. What are some of the biggest takeaways for nurses caring for patients with DKA or HHNS?
Well, the materials you shared really emphasize a few things. First, understanding sick day insulin, especially for kids with type 1 diabetes.
Oh yeah, sick day insulin. Can you remind us what that is?
So even if a child is sick, not eating, even throwing up, they still need insulin to prevent DKA. Illness can actually make blood sugar levels go up, and skipping insulin can make things way worse. Sick day insulin protocols help us adjust insulin doses during those times.
Right, that's important. What about potassium management?
Both high and low potassium can be life-threatening, so we got to be super vigilant. Continuous heart monitoring is a must during potassium administration, and IV potassium needs to be given slowly and through a central line to avoid any complications.
Okay, that makes sense.
Okay.
Any other key nursing considerations?
Yeah, the sources also stress how important continuous reassessment is. Hourly blood glucose checks are standard, and we're constantly checking for signs of rehydration.
What are some things nurses look for to assess hydration?
Well, stable blood pressure is a good sign. Good capillary refill, too, meaning the color returns quickly to the nail bed after you press on it. Warm skin and good urine output are also positive signs. And of course, we're always watching for any changes in mental status, especially in HHNS.
So basically, eyes on the patient at all times.
Exactly. Nurses are like the front line. Their observations and interventions can literally save lives in these situations.
Absolutely.
And they're not just managing the medical stuff, they're also providing education and support to patients and their families.
Speaking of patient education,
Yeah.
what are some key things nurses can do to help patients manage their diabetes better?
One of the most important things is just teaching them about the condition itself. Explaining the difference between type 1 and type 2, how insulin works, what can affect blood sugar levels. And we talk about potential complications like DKA and HHNS, what to watch out for.
So it's like giving them the tools to understand their own body.
Yeah, and we also focus on practical skills, like how to check blood sugar, how to give insulin injections, and how to adjust dosages based on their needs and lifestyle. We talk about healthy eating, regular exercise, taking medications as prescribed. It's all about helping them create a plan that works for them.
A personalized roadmap.
Exactly.
It sounds like patient education is a team effort.
It is. It's about empowering patients to be active participants in their own health. And that can make a huge difference in preventing complications down the road.
It's not just managing diabetes. It's thriving with it.
Exactly.
Before we move on, I saw something about metabolic syndrome in the materials.
Yeah.
What is that, and how does it relate to what we've been talking about?
Great question. It's not directly linked to DKA or HHNS, but it's a big risk factor for type 2 diabetes, heart disease, and stroke. Basically, it's a bunch of conditions that tend to occur together,
Yeah.
and they increase a person's risk for these serious health
Okay,
problems.
I'm starting to see the connection. So what are the components of metabolic syndrome?
There's a handy mnemonic to remember them. BOL. B is for BP meds or HTN, meaning they need blood pressure meds. Or they have hypertension, which means their systolic blood pressure is consistently over 130.
Okay, and the O.
O is for obese, which in this case means having a large waist circumference. For women, that's 35 inches or more. For men, it's 45 inches or more.
So just measuring their waist can tell us a lot.
Yep, it's a simple measurement, but it's a strong indicator of increased health risks.
And the L?
L is for lipids, HIGH. This means they have high cholesterol, high triglycerides, and high LDL cholesterol, which is the bad kind. But their HDL cholesterol, the good kind, is lower than we'd like.
So high blood pressure, a large waist, and messed up cholesterol levels. That's a recipe for trouble.
Exactly. It's like a warning sign that the body's not processing energy well. And their risk for serious health problems is way higher.
This really highlights why catching it early is so important. What can we do to help people with metabolic syndrome lower their risk?
Lifestyle changes are key. We encourage people to eat healthy, cut back on saturated and trans fats, eat more fiber, choose whole grains over processed foods, and regular physical activity is crucial. Aim for at least 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise each week.
So it's all about moving more and eating better.
Pretty much. Sometimes medications might be necessary to manage blood pressure or cholesterol, but the focus is always on making lasting lifestyle changes that improve overall health.
Not just a quick fix, but a long-term solution.
Exactly.
This has been really eye-opening. We've covered so much, from the immediate dangers of DKA and HHNS to the bigger picture of diabetes management and metabolic syndrome. And it's clear that nurses are essential every step of the way.
I couldn't agree more. And nurses are the backbone of diabetes care. Their knowledge, compassion, and advocacy are so important for helping people navigate this complex condition and helping them live healthier, more fulfilling lives.
Absolutely. Before we wrap up this part, I'd love to unpack the different types of insulin and how they're used in diabetes management. It can be a bit confusing, so I'm hoping you can shed some light on it.
You bet. It's like having a toolbox full of different wrenches. You need the right one for the job.
Okay, I like that analogy. So what are the main types of insulin, and how are they different?
Well, the materials you sent me talk about several main categories of insulin, from rapid-acting to long-acting. Each one is designed to mimic the way the body naturally releases insulin as closely as possible.
That makes sense. So walk us through each type, starting with the fastest-acting ones.
Sure. Rapid-acting insulins like Lispro, Aspart, and Glulisine, think of them like sprinters. They kick in quickly, usually within 15 minutes, peak in about an hour, and then they're out, lasting only 2 to 4 hours.
So these are the ones you'd use around meal times to handle those blood sugar spikes.
Exactly. They're often taken right before or even after meals to match the rise in blood glucose from the food.
Makes sense. What about regular insulin? I know that one's been around forever.
Yeah, regular insulin is more like a middle-distance runner. It's slower than the rapid-acting insulins. Takes about 30 minutes to start working, peaks in 2 to 3 hours, and lasts for 5 to 8 hours.
So not as fast, but covers a longer time period.
Right. Regular insulin can be used for both mealtime coverage and to provide a more consistent level of insulin in the background. And don't forget, it's the only type that can be given intravenously, which is why it's so important for treating DKA and HHNS in the hospital.
Right. IV insulin is a lifesaver in those situations. Yeah. Okay, so we've covered the fast-acting ones. What about the insulins that provide longer coverage?
That's where intermediate-acting and long-acting insulins come in. NPH insulin, which is intermediate-acting, is like a marathon runner. Takes about 2 hours to start working, peaks in 4 to 12 hours, and can last for 12 to 18 hours.
So it's a slower, more gradual release of insulin.
Yes, and it's often used together with rapid-acting or regular insulin to provide both mealtime and background coverage.
Okay, that makes sense. And what about the long-acting insulins? Those are the ones people usually take once a day, right?
You got it. Long-acting insulins like Glargine and Datamir are like ultra-marathoners. They release insulin slowly and steadily over 24 hours, providing a constant background level of insulin without those big peaks and valleys.
That sounds perfect for keeping blood sugar levels stable throughout the day.
It is. They've been a game changer for a lot of people with diabetes, especially those with type 2. They mean fewer injections and a more predictable insulin delivery.
That's great. This is all super helpful. But I know that giving insulin correctly is just as important as picking the right type. What are some things nurses really need to know about giving insulin?
The materials you sent highlight some great points. One of the most important things is to make sure the insulin peaks line up with meal times. This helps prevent hypoglycemia, especially with the faster-acting insulin.
Timing is everything.
Absolutely. Another important thing to remember is that long-acting insulins like Detamir and Glargine don't have those distinct peaks, so you can't mix them with other insulins in the same syringe.
Right. No peak, no mix.
Exactly. Easy to remember.
Okay, what else?
Another classic nursing school saying is, draw up, clear to cloudy. That's for when you're mixing different types of insulin in the same syringe. Always draw up the clear insulin first, usually your rapid-acting type, then the cloudy insulin, which is usually an intermediate-acting type. This prevents contamination.
Oh yeah, that's drilled into us from day one.
And for good reason. It helps prevent medication errors.
What about where you give the injections? I know those need to be rotated, right?
Yep, rotating injection sites is super important. It helps prevent lipohypertrophy, which is a buildup of fatty tissue that can mess with how well the insulin is absorbed. Think of it like watering a plant in the same spot over and over. The roots get all bunched up.
I get it. So is there a best place to give insulin injections?
Generally, the abdomen is the go-to spot. Injecting a couple of inches away from the belly button, it absorbs well and it's easy to reach.
Okay, good to know. Any other insulin tips?
Well, we already talked about sick day insulin for kids with type 1, but it's always worth repeating.
Definitely a life-saving concept.
And last but not least, nurses need to be ready to handle hypoglycemia. That's when blood sugar drops too low, usually below 70. The key is to check how alert the patient is.
So how do you approach hypoglycemia differently depending on whether the patient is conscious or not?
If they're awake and can swallow, we give them something sugary to drink, like juice, regular soda, or low-fat milk. But if they're out of it, we need to act fast. We might give intravenous dextrose, usually D50, to get their blood sugar up quickly.
So in those cases, every second counts.
You got it. Hypoglycemia is a medical emergency that needs to be treated right away.
This has been a really helpful overview of insulin, but I know insulin isn't the only tool we have for managing diabetes. What about oral hypoglycemic medications?
Oh yeah, those are mainly used for type 2 diabetes. And they work in different ways to help the body either make more insulin, use insulin better, or slow down how fast glucose is absorbed from the gut.
There are a lot of different types of those medications. Can we go through some of the main ones mentioned in the materials I sent you?
Absolutely. Metformin is often the first choice for type 2 diabetes. It works by reducing glucose production in the liver and improving insulin sensitivity in the body's cells.
Okay, and what are some key things nurses should know about metformin?
Well, one of the big pluses is that it doesn't usually cause hypoglycemia, especially when it's the only medication being used. But it can cause some stomach upset, like nausea and diarrhea, especially when you first start taking it.
So starting with a low dose and gradually increasing it can help.
Exactly. And it's important to remember that metformin can interact with alcohol and some other medications, so patient education is really important.
What about other things to watch out for with metformin?
We need to monitor kidney function in patients taking metformin because it can increase the risk of lactic acidosis if the kidneys aren't working well. It's a serious condition, but it's rare. Also, metformin needs to be stopped for a bit before any procedures that use intravenous contrast die, because that combination can also put stress on the kidneys.
So careful monitoring and patient education are key. What about other oral medications?
Sulfonylureas, like glipizide and glyburide, are another group. They tell the pancreas to release more insulin. They can be really effective at lowering blood sugar, but they have a higher risk of hypoglycemia, especially if someone drinks alcohol or skips meals.
So timing those meals and medications is crucial.
Absolutely. And it's important to note that sulfonylureas can be harmful to the liver and kidneys, so they might not be right for everyone.
Okay, what else is commonly used?
Thiazolid and diones, or TZDs like pioglitazone, they work by improving insulin sensitivity in the body's cells. They're good at lowering blood sugar. But they come with their own set of considerations.
Like what?
TZDs can cause fluid retention, so we don't use them in patients with heart failure. They can also make liver function worse, so they're not an option for patients with liver disease.
It sounds like picking the right medication for each patient is like walking a tightrope.
It is. It's a personalized decision. We have to consider the patient's needs, medical history, lifestyle, and preferences. Nurses play a huge role in educating patients about their options and helping them make informed decisions.
This has been incredibly insightful. We've covered so much ground today. DKA, HHS, insulin, oral medications, and the critical role nurses play in all of it. What are some of the key takeaways you want our listeners to remember?
Well, the most important thing is that diabetes is complex. It needs a whole person approach. It's not just about numbers on a blood sugar meter. It's about empowering people to live well with diabetes. And that takes knowledge, teamwork, compassion, and a commitment to always learning and getting better. We, as healthcare providers, need to stay up to date on the latest research, treatments, and best practices so we can give the best possible care.
I couldn't have said it better myself. This deep dive has been a fantastic learning experience for me, and I hope our listeners feel more informed and empowered to make a difference for people with diabetes.
Me too. By sharing knowledge, working together, and approaching diabetes care with compassion and a drive to be excellent, we can really change lives.
Thank you so much for joining me for this deep dive.
It's been a pleasure.
And to our listeners, thanks for being here with us on this journey of knowledge and discovery. Until next time, keep exploring, keep learning, and keep diving deep into the world around us.
I'll second that.
All right, let's shift gears a bit and talk about some specifics. Insulin.
Okay, sounds good.
There are so many different types.
Yeah, it can be a bit overwhelming.
Can you break it down for us?
Absolutely.
What are the main categories and how do they differ?
Well, the materials you shared outline several key types of insulin, each designed to mimic the body's natural insulin release patterns as closely as possible.
Makes sense. So let's walk through each type, starting with the fastest acting ones.
Okay, so rapid-acting insulins like Lispro, Aspart, and Glulisine. They're like sprinters. Kick in quickly, usually within 15 minutes, peak in about an hour, and have a relatively short duration of action, typically lasting 2 to 4 hours.
So these are the ones you'd use around meal times to cover those immediate spikes in blood sugar.
Exactly. They're often taken right before or even after meals to match the rise in blood glucose from the food.
Okay, that makes sense. And what about regular insulin? I know that's been around for a long time.
Oh, yeah. Regular insulin is kind of like a middle-distance runner, a bit slower than the rapid-acting insulins. Takes about 30 minutes to start working, peaks in 2 to 3 hours, and lasts for 5 to 8 hours.
So it's not as fast on the uptake, but covers a longer period.
Precisely. Regular insulin can be used for both mealtime coverage and to provide a more sustained background level of insulin. And remember, it's the only type of insulin that can be given intravenously, which is why it's a mainstay for treating DKA and HHS in hospital settings.
Right, that's crucial in those acute situations. Okay, so we've covered rapid acting and short acting. What about those that provide longer coverage?
That's where intermediate acting and long acting insulins come in. NPH insulin, an intermediate-acting insulin, is like a marathon runner. It takes about 2 hours to start working, peaks in 4 to 12 hours, and can last for 12 to 18 hours.
So it provides a more gradual and sustained release of insulin.
Yes. And it's often combined with rapid-acting or regular insulin to provide both mealtime and background coverage.
Gotcha. And what about the long-acting insulins? Those are the ones people often take once a day, right?
You got it. Long-acting insulins, like Glargine and Detamir, are like ultra-marathoners. They release insulin slowly and steadily over 24 hours, providing a consistent background level of insulin without distinct peaks.
That sounds ideal for keeping blood sugar levels stable throughout the day.
It is, and they've really revolutionized diabetes management for many people, especially those with type 2 diabetes. They help reduce the burden of multiple daily injections and provide a more predictable insulin delivery.
This is all incredibly helpful. But I know that administering insulin correctly is just as important as choosing the right type. What are some key things nurses need to keep in mind when it comes to insulin administration?
The sources you provided highlight some excellent points. One of the most important things is to match insulin peaks with meal times to prevent hypoglycemia, especially with the faster-acting insulins. Remember the saying, hypogly brain will die?
Oh, wow. That's certainly memorable.
Right.
What else?
Another important point is that long-acting insulins, like Detamir and Glargine, don't have those distinct peaks, so they can't be mixed with other insulins in the same syringe.
So it's no peak, no mix.
Exactly.
Okay, what else should nurses be mindful of?
A classic nursing school mantra is draw up, clear to cloudy, when mixing different types of insulin in the same syringe. Always draw up the clear insulin, usually a rapid-acting type, before the cloudy insulin, which is typically an intermediate-acting type. This helps avoid contamination.
That's one of those fundamental things that's drilled into us from day one.
Right, for good reason.
What about injection sites? I know those need to be rotated to prevent problems.
Absolutely. Rotating injection sites is key. It helps prevent lipohypertrophy. which is a buildup of fatty tissue that can interfere with insulin absorption. Think of it like overwatering a plant in the same spot. The roots get congested.
That's a great analogy. And is there an optimal site for insulin injections?
The abdomen is generally the preferred site. Injecting about 2 inches away from the belly button, it tends to have good absorption, and it's relatively easy to access.
Okay, good to know. What other insulin tips do you have for us?
Well, we've already talked about the importance of sick day insulin for children with type 1 diabetes.
Absolutely, that's a life-saving concept.
Last but not least, nurses need to be prepared to manage hypoglycemia, which is when blood sugar levels drop too low, usually below 70 milligdl. The key here is to assess the patient's level of consciousness.
So how do you approach hypoglycemia differently, depending on whether the patient is conscious or not?
If the patient is awake and able to swallow, we'll give them something sugary to drink, like juice, regular soda, or low-fat milk. But if they're sleeping or unresponsive, we need to act more quickly and might administer intravenous dextrose, typically D50, to raise their blood sugar levels rapidly,
Okay.
to raise their blood sugar levels quickly.
That makes sense. Time is of the essence in those situations.
Absolutely. Hypoglycemia is a medical emergency. It requires prompt recognition and treatment.
This has been a really helpful overview of insulin, but I know insulin isn't the only tool we have for managing diabetes. What about oral hypoglycemic medications?
Oh, yeah. Those are primarily used for type 2 diabetes. They work in various ways. Some help the body produce more insulin, some help the body use insulin more effectively, and some slow down the absorption of glucose from the digestive tract.
There are so many different classes of these medications. Can we walk through some of the key ones mentioned in the materials I sent?
Of course. Metformin is often the first-line medication for type 2 diabetes. It works by reducing glucose production in the liver and by improving insulin sensitivity in the body's cells.
Okay, what are some key things nurses should know about metformin?
One of the big advantages of metformin is that it has a minimal risk of causing hypoglycemia, especially when used alone. However, it can cause gastrointestinal side effects, like nausea and diarrhea, especially when starting out.
So starting with a low dose and gradually increasing it can help minimize those side effects.
Exactly. And it's important to note that metformin can interact with alcohol and certain medications, so patient education is key.
Are there any other potential concerns with metformin?
Yeah. It's important to monitor kidney function in patients taking metformin, as it can increase the risk of lactic acidosis, a serious but rare condition, if the kidneys aren't working properly. Also, metformin needs to be stopped temporarily before any procedures involving intravenous contrast die, as the combination can also stress the kidneys.
Okay, so careful monitoring and patient education are essential with metformin. What about other oral medications?
Sulfonylureas like glipizide and glyburide, they're another class of medications. They stimulate the pancreas to release more insulin. They can be quite effective in lowering blood sugar levels, but they carry a higher risk of hypoglycemia, especially when combined with alcohol or skipped meals.
So patients need to be really diligent about timing their meals and medications with these drugs.
Absolutely. And it's important to note that sulfonylureas can be toxic to the liver and kidneys, so they might not be suitable for everyone.
Okay, what other medications are commonly used?
Thiazolidinediones, or TZDs, like pioglitazone, work by improving insulin sensitivity in the body's cells. They're effective in lowering blood sugar, but come with their own set of considerations.
What are some things nurses should be aware of with TZDs?
Well, TZDs can cause fluid retention, so they're not suitable for patients with heart failure. They can also worsen liver function, so they're contraindicated in patients with liver disease.
It sounds like choosing the right medication for each patient is a complex decision. It involved weighing the potential benefits against the potential risks.
Exactly. It's a personalized decision. It takes into account the patient's individual needs, medical history, lifestyle, and preferences. Nurses play a vital role in educating patients about their medication options and helping them make informed decisions about their care.
Wow, we've really covered a lot of ground today. We've explored the intricacies of DKA and HHS, delved into the complexities of insulin and oral medications, and highlighted the crucial role nurses play in every step of the diabetes management journey. What are some key takeaways you'd like to leave our listeners with?
I think the most important thing to remember is that diabetes is a multifaceted condition. It demands a holistic approach. It's not just about managing blood sugar levels. It's about empowering individuals to live well with diabetes. And that requires knowledge, collaboration, compassion, and a commitment to ongoing learning and improvement. As healthcare providers, we have a responsibility to stay up to date on the latest research, treatment options, and best practices so we can provide the highest quality care possible.
I could have said it better myself. This deep dive has been an incredible learning experience for me, and I hope our listeners feel equally informed and empowered to make a real difference in the lives of people living with diabetes.
I agree. By sharing knowledge, fostering collaboration, and approaching diabetes care with compassion and a commitment to excellence, we can truly transform the lives of those affected by this condition.
Thank you so much for joining me on this deep dive. It's been an absolute pleasure.
The pleasure was all mine. It's always a joy to delve into these important topics and share insights with fellow healthcare professionals.
And to our listeners, thank you for joining us on this journey of knowledge and discovery. Until next time, keep exploring, keep learning, and keep diving deep into the fascinating world around us.
Rapidly.
Right, to raise their blood sugar levels quickly. That makes sense. Time is of the essence in those situations.
Absolutely. Hypoglycemia is a medical emergency. It requires prompt recognition and treatment.
This has been a really helpful overview of insulin, but I know insulin isn't the only tool we have for managing diabetes. What about oral hypoglycemic medications?
Oh yeah, those are primarily used for type 2 diabetes, and they work in a few different ways. Some help the body make more insulin, others help the body use insulin more effectively, and some slow down how fast glucose is absorbed from the digestive tract.
There are a lot of different types of those medications. Can we go through some of the main ones mentioned in the materials?
Of course. Metformin is often the first choice for type 2 diabetes. It works by reducing how much glucose the liver makes and by improving how sensitive the body's cells are to insulin.
Okay, so what are some key things nurses should know about metformin?
One big advantage of metformin is that it's not likely to cause hypoglycemia, especially when it's the only medication someone is taking, but it can cause some stomach issues, like nausea and diarrhea, especially when people first start taking it.
So starting with a low dose and gradually increasing it can help.
Exactly. And it's important to remember that metformin can interact with alcohol and some other medications, so patient education is really important.
What about other things to watch out for with metformin?
It's important to check kidney function in patients taking metformin. If the kidneys aren't working well, it can increase the risk of lactic acidosis. That's a serious but rare condition. Also, metformin needs to be stopped for a bit before any procedures that use intravenous contrast die, as the combination can also put a strain on the kidneys.
Okay, so careful monitoring and patient education are key. What about other oral medications?
Sulfonylureas, like glipizide and glyburide, are another group. They work by telling the pancreas to release more insulin. They can be really effective at lowering blood sugar levels, but they have a higher risk of hypoglycemia, especially if someone drinks alcohol or skips meals.
So timing those meals and medications is crucial.
Absolutely. It's also important to remember that sulfonylureas can be hard on the liver and kidney, so they might not be a good fit for everyone.
Okay, so what other medications are commonly used?
Thiazolidinediones, or TZDs for short, like pioglitazone, are another option. They work by improving insulin sensitivity in the body's cells, so they help the cells use insulin more effectively. They're good at lowering blood sugar, but they have their own considerations too.
Like what?
TZDs can make the body hold on to extra fluid, so they're not a good choice for patients with heart failure. They can also be tough on the liver, so we avoid them in patients with liver disease.
Wow, it sounds like picking the right medication for each patient is a real balancing act.
It is. It's a decision that needs to be individualized, taking into account the patient's needs, medical history, lifestyle, and preferences. Nurses play a big role in educating patients about their options and helping them make informed decisions.
This has been so insightful. We've covered DKA, HHS, insulin, oral medications, and the incredibly important role nurses play in it all. As we wrap up this deep dive, what are some of the key takeaways you want our listeners to remember?
I think the biggest thing is to remember that diabetes is a really complex condition. It requires a holistic approach. We can't just focus on blood sugar numbers. We need to empower people to live full and healthy lives with diabetes. And that requires knowledge, collaboration, compassion, and a willingness to keep learning and improving. We, as healthcare providers, need to make sure we're up to date on the latest research, treatment options, and best practices so we can give the best possible care.
That's so well said. This deep dive has been a fantastic learning experience for me, and I hope our listeners feel the same way. I hope they feel equipped and inspired to make a difference for people living with diabetes.
Me too. By sharing knowledge, supporting each other, and approaching diabetes care with compassion and a commitment to excellence, we can truly change lives.
Thank you so much for joining me today.
It's been a pleasure.
And to our listeners, thank you for being here with us on this journey of exploration and discovery. Until next time, keep learning, keep asking questions, and keep diving deep into the world of healthcare.